All righty, thank you, Lisa. Let's get rolling. This is one of my favorite topics to discuss. Actually, it's been immediate molar implants has probably been one of the largest practice building procedures we've done in our private practice. It saves the patient so many visits, so much time, saves them money, and gives them better results. And we've been teaching this procedure for years now, and I would say the majority of general dentists that place implants are perfectly capable of learning this and implementing it into their practice. Of course, the goal is to elevate the standard of care. You're getting old when you want to start a book club, but there's a few good books out there that I like to implement when we give these presentations. This is a great book by Brandon Webb called Total Focus that implements kind of if you will, the stoic and hardcore mindset of special ops into our practices, into business. But what I'd like to mention tonight from his book is the quote, "Never be so sure of yourself that you won't do something better. Excellence matters." And what I mean by that is in our practices, of course, we take an oath to do good and do no harm. The way I define that is to provide the most conservative, enduring aesthetic treatment. And when we think of conservative, we think of physical, we think of emotional, we think of financial. And of course, it's got to last. And most of our patients, especially here in the US, want everything to look absolutely gorgeous and perfect. And we can do that through evidence-based dentistry and applying these principles that we're going to learn tonight. So I've been in practice for 15 years now. It's been nice to be able to see these side by side, and of course, split mouth anecdotal designs, if you will, on our treatments. This is a patient that we've been seeing for well over a decade now. Of course, the implant number 31, that second molar, is a delayed placement. So kind of think of it like the old school conservative, hey, let's take this tooth out, do a socket preservation, allow it to heal 4 months. Of course, the patient doesn't make it back in time. Right at that 4 months, it ends up getting placed at 6, 7, 8 months. So we're dealing with some atrophy. Quite often, we're then 4 to 6 months later making an impression and eventually putting a crown on. Now that works. However, we have better options such as these immediate molars. And so what's tough on these patients, for those of you that have been in practice for a while, is when you provide the same treatment more than once to the same patient and they get a different result, or they see that contrast. So this patient was concerned, said, "Hey doc, I spent all this money on this back implant, this back crown, and it doesn't look as good, it doesn't feel as good, and it gets a lot more food stuck around it than the first one. Why? What's the difference?" And so if we consult the literature, and I'll try not to belabor this too much, but it is important that we implement some science behind this. The literature states that 44.7% of implant patients are dissatisfied with food impaction. Most of us that have done a decent number of implants in our practices have experienced that with our patients. Of course, fake teeth will never feel perfectly real, we like to say in our practice, but we should try everything humanly possible to get things as normal and feeling as and long lasting as possible. The other situation that we run into quite often with these large molars on smaller diameter implants is the abnormal emergence profiles that create food traps and or difficulties to clean. So what's really interesting, a recent study by Smith et al. Showed that 40% of teeth with a larger, they call it a tooth to implant distance than 6 millimeters, had an increase in 40% of proximal decay. So of course, the closer we can get these emergence profiles and implants to natural forms, the easier it'll be for these patients to take care of. So we've got food impaction almost half, proximal caries in over 40%. Why does this happen? Well, this is well documented in the literature by Araujo and et al. Classic lit in oral surgery, periodontics, and prosthodontics. We get 3 times more bone loss, dimensionally, if you will, in delayed placement versus immediate placement. That begs the question, though. I teach residents, and we've also taught CE courses for over a decade. isn't there a higher failure rate with immediate implants? And the answer is, well, it's negligible. It's less than 1%. So we've got a 0.91% difference, if you will, in immediates versus delayed. One of the big components, though, a lot of our residents in continuing education course, doctors, attendees ask, can you place implants in infected sites? And my answer is, well, don't we place fillings where caries used to be? So if we can completely remove the infection and meticulously curettage it out, debride it, this systematic review recommends chlorhexidine as a chemical debriding agent, not a post-op application for post-op use, but simply intraoperatively, we can get great results within reason on these types of teeth. So we're going to jump right into the first case. Obviously, it's tooth number 30. There's already some pre-existing recession on the free gingival margin, especially that buccal area with limited attached tissue. And what's fun about this case is we're going to be able to regenerate some of that attached tissue by just proper implant placement, grafting, and provisionalization in the form of a custom healing cap, so we can get that healing by secondary intention. So of course, one of the most important things to do when you're using your CT scan is to rotate the image so that your measurements are going along the long axis that you're planning on placing that implant. We see attendees and residents all the time that take a CT scan, they're measuring at the wrong angle. So please familiarize yourself with the rotation tool to make sure that you're rotating that computed tomography image, the CT image, to its appropriate angle, if you will, or vector. Then we're going to come in and we're going to do a minimally invasive extraction. Translation, I always recommend removing the crown and sectioning those roots and rotating them out one at a time. It doesn't really matter. Sometimes doctors ask, which root do I rotate out first? Honestly, it's the one that luxates the most first. Remove it. Then you can go in and remove a little bit more interradicular bone if needed, and tip the more difficult root into the void, if you will, of the root you just removed. I've found that typically we're removing the mesial first and then the distal in these mandibles, but there's really no rhyme or reason. One of the interesting things here now is we want to obviously do our mechanical curettage, just curette that. Yes, we use chlorhexidine. This was an infected site with chronic apical perio. But judiciously, you need to say, well, if the osteotomy and the future implant placement completely remove that infection, then we're in good shape. So patient comes in with giant abscess, visible swelling, that's definitely not an immediate molar case. But if the infection resides in a small kind of teardrop shape, the tip of the root, and it's obliterated by your osteotomy, then you have a great prognosis on placing an immediate implant. That holds true for the anterior as well. So then we go through the sequence. We're going to go over this a little bit more with a few more cases of drilling. You have to be cautious and careful of this drilling, though. You have to imagine as if you have two little holes drilled in a 2x4 and you're trying to drill a hole in the middle. So what happens in the mandible is you really do need to lean and give it what we call lingual bias when you're drilling for that immediate molar, anticipating that each subsequent drill will drift to the buccal. These are really tough procedures, these immediate placements of any kind, to be predictable with surgical guides, because you want to be able to look, you want to be able to listen, you want to be able to feel, and you want to be able to mitigate and pivot when you see deflection of those drills, so you can correct it. So I'm not against guided surgery. I'm just saying in these immediate application, it loses a lot of its advantage. Because now you're drilling essentially blind, deaf, and dumb, because you can't see anything, you can't hear anything, you can't feel anything. So the ways to work around this are to start that osteotomy against the lingual plate and allow it to drift via cortical deflection to the buccal. The most important part of placing this implant is that we're 4 millimeters deep, called the 4 millimeter rule, to the anticipated or preferred free gingival margin, and we're 3 millimeters away from that facial plate. These immediate molar implants get a bad rap in the literature if they're placed improperly. Translation, you cannot place these against the facial plate. You should never do that in the aesthetic zone either. You will get resorption via avascular necrosis over time. So make sure that you're placing these literally against the lingual plate to maintain that gap space to graft on the buccal. In this particular application, we used corticocancellous, just a 50-50 graft mix. Sometimes we'll mix that with LPRF, sometimes we won't. But in all honesty, we use mostly the Mineros putty that you'll see up here in these future cases more often than not. So now what we want to do, we've got our implant placed 4 millimeters deep, 3 millimeters away from the facial plate, grafts in both the distal and the mesial root. Now we want to make a custom healing abutment. The idea is to preserve and support those tissues that we just had extracted that tooth out of. Best way to do that is place our little temporary cylinder. We can then use flowable composite, or my preferred is a bisacryl. Any of your temporary crown materials, we'll show more of those in a minute. Light it up, remove it. You can place a traditional healing abutment here, but then you want to take that out and just polish that up. If there's some voids, sharp spots, feel free to add composite there. The literature's clear. We want to make sure we have a concave emergence profile. So from that analog out to the periphery of that crown, it's beneficial to use these large convex diameter drills, smooth that out, polish it, and now we have the ideal custom healing abutment or custom healing cap, whichever you'd like to call it. I'm kind of old school. I let these heal for a full 4 months. There's nothing in the aesthetic zone to worry about. I'd rather have a tissue and bone heal too much than not enough. And then very predictably, we can remove that custom healing cap. And this is a huge, huge, huge advantage. Of course, we're going to be able to digitally scan our emergence profile. And that does a few things. The nice thing is now there's no confusion with the lab as to what shape do we want this implant crown, preferably screw retained implant crown, to emerge from the implant. And probably the biggest benefit, though, is now our patients come in, we're making impressions, not having to get them numb, not pinching them. They come in again for delivery. It shouldn't be more than a 5-minute delivery. There's no numbing a patient up, hoping the crown goes all the way down. It's really worth doing on that surgical date, just to save you the time and the headache down the road, like most things in dentistry. So, of course, we've got our digital scan of the emergence profile, digital scan of the scan flag. The lab can then generate the ideal CAD/CAM crown. Literature is clear. We want the emergence profile to be between 25 and 45 degrees. Anything less doesn't support tissues. Anything more tends to suffocate tissues. And the idea is we can then torque this one-piece zirconia screw retained implant down, crown down to our implant. So did we do good? Did we do no harm? The nice thing about this procedure is it was one surgery, one time. Total treatment time 5 months versus the traditional way. If we look at that number 31 on that patient, if we go back here, this was a 9 to 10 month procedure, almost twice as long, double the surgery, double the time in the chair, and the patient doesn't get the same great result, and obviously not the same level of patient satisfaction. So the whole goal is to optimize patient satisfaction, but also optimize doctor satisfaction. If we can do treatments that are less stressful, more predictable, patients are happier, staff's happier, doctors happier, and it's a more fulfilling career. These are some of the key articles. We're not going to beat this, belabor this too much, but this has been around for over 20 years. John Coyce and Joe Kahn wrote an article on the appropriate implant depth relative to the free gingival margin being 4 millimeters, hence the 4 millimeter rule. Systematic review on making sure we stay 3 millimeters away from the facial plate and we graft that gap between the implant and the facial plate. Tarnow, Chu, and his group at NYU have shown that the best soft tissue and hard tissue preservation come from immediate implants with gap grafts and immediate provisionals. Now, we didn't show you an immediate full contour provisional, but essentially these custom healing abutments are a crown with the top cut off, and they essentially do everything that these immediate temporary provisionals or provisional crowns do at preserving both bone height and tissue height and width. Of course, if we incorporate a platform switch implant, we get even more tissue thickness, but it's critical that when we make these custom healing abutments and or these immediate provisionals that we have a concave profile, emergence profile. One of the best ways to do that is with the direct injection technique. We're going to show that with a few more cases and finish this literature review up with, it's important to know that there are only 3 materials that tissue will truly adhere to in the form of hemidesmosomes, desmosomes, as far as epithelial attachment goes, and they are titanium, zirconia, and acrylic. So for our final restorations, we want to get as much zirconia, not glazed with ceramic, subgingivally, and that'll help fight apical migration of tissue over time and decrease the chances of food impaction, of course, secondary to that, proximal caries. So we're going to move forward with another case now. This will be a little bit more illustrative, if you will, step by step. This is the number 30 all over again. I'm a right-handed operator. Yes, most of these are going to be right hand. They're just easier to take pictures of. But this patient failed root canal, chronic apical perio for quite some time. Obviously, we removed the crown and sectioned through the bifurcation of this tooth. And you have to, this goes back again to the look, listen, feel. You should be able to see that this sectioning going on from the buccal to the lingual. You should be able to hear the difference once you get through that dentin and cementum. Obviously, it sounds more dull when you're in the bone and the bifurcation. And then you're going to obviously be able to feel the varying resistance as you get down into bone. We can then go ahead and elevate out. The goal is to ever so gently remove these roots. Again, I highly recommend that you simply section them every time. What's really important, I see this happen all the time, is doctors skip the step of mechanically debriding that infectious tissue. If you don't get this granulation tissue out, there is a high probability that that could remain infected. And so mechanical debridement followed by chemical debridement, followed by laser sterilization, or whatever you want to call that, disinfection, are the 3 things that we use in our practice to help rid that site that we place these immediate implants in of any infection. So as we move forward, this better depicts, if we go, this is just a standard surgical burr. It's a 701. So it's the same drill that we use to section the roots. And you can use that to create a purchase point along the lingual plate between the mesial and distal root. Fairly simple. The goal is to accept and to anticipate the fact that as each successive drill comes in and butts up against that lingual plate, it deflects off to the buccal. So some of the drills we've been using recently, if there is significant septal bone to expand, are the Versa osteodensification drills. Those work wonders. When you do have bone that's densifiable, if you will, anything more dense than D3, D4 bone, that's unwise. You're going to end up burnishing and just basically overheating bone and or killing it. So some people say, well, why would you use Versa if you're still going to go in and use the final drill? The nice thing about the Versa drill spinning backwards is they don't chatter. So anybody that's done any carpentry in their life trying to drill a hole between 2 holes, the risk is that that drill is going to drift whatever way that drill's spinning into one of the pre-existing holes, or in this case, the socket. So the nice thing about the Versa, it's a lot easier to hold true, create that osteotomy, establish the vector and the depth, and then you can go in with a final drill if needed for these implants. This is the putty. So this is BioHorizons Mineros. It's 50/50 cortical cancellous putty. This is a great material to use. I tell patients this is almost like a caulk that you can put between the implant and the roots, and then of course between the implant and the facial plate. It also has incredible characteristics as far as being able to handle it well. The whole goal is to get this implant in, fill those voids with bone graft material, and what we'll show here is we kind of just tap it with a sterile Q-tip and create the ideal emergence profile for making this custom healing abutment. So this is the 7x10 implant from BioHorizons. Remember, we're placing these 4 millimeters deep to the free gingival margin, 3 millimeters away from the facial plate. The only time I've gotten myself in trouble is when I try and be a cowboy and I feel, shame, if you will, for not being able to get this immediate implant in. Then we jump it up to an 8. That gap gets smaller. We end up with recession over time. And then you end up having to start all over again. So just have the discipline to maintain these parameters, 4 millimeters deep, 3 millimeters away, and you won't find yourself in that trap. Also, some of the literature that's not positive about immediate molar implants really has to do with the placement. They need to be 3 millimeters away from the facial plate, 4 millimeters deep to the tissue. So then we're going to take, this is BioHorizons laser lock. So scientifically proven to engage more tissue cells down here. Temporary cylinder. Now this is engaging. You can see the hexagon here. We'll go down inside of the implant. It's an anti-rotational feature. We can then torque on the abutment, and then we can inject the bisacryl that we'd use to make a single temporary crown directly into that site. So this is important. I can't tell you how many times we've made these. After a while, you should be able to fabricate these in 10 to 15 minutes max. You're definitely going to want to charge out a 6051 temporary abutment, 6085 temporary crown that's cut off at the top. But long story short is, if you don't put some sort of index so you know which way it goes, you're going to have a heck of a time getting that in. So you'll notice this little dimple that we put over here on this side, so we know that's to the buccal. By the time we take that out, we can trim it, we can polish it. We do all of this at our hands-on courses that you'll see some not necessarily promos, but just flyers for here in a minute. I truly believe you got to do this hands-on. You can't just watch it, but ultimately we can screw down this custom healing abutment and preserve all the tissue and bone that was in that area. Patient can then come back 4+ months later. These are big teeth, especially in the maxilla. Yes, we can get some high torque on these, but that does not mean we have a high percentage of bone to implant contact, which is really what's most important. So, sometimes in the posterior maxilla will allow even 6 months of healing, just because I don't want to deal with anything failing or twisting prematurely. Plus, it's not in the aesthetic zone, so it's not as aesthetically taxing. So here we are, same process. Going to remove the custom healing abutment, do our digital scan to capture that emergence profile, generate our ideal CAD crown, check it on the 3D model. Know that this is completely screw retained, full contour zirconia with just basically a short tie base. Technically, it's not short, it's got a tall chimney in it on these applications. So, like we said before, the whole goal is to do good, do no harm, do the most conservative physically, financially, and emotionally treatment that endures and lasts, and optimize patient satisfaction. And sometimes I say, what about optimizing doctor satisfaction? And we get a lot of yeah buts. You do this in your practice, but I can't do this in my practice. And a lot of it really boils down to lack of ability to treatment plan. So because of that, in my own practice, we put together a software called Implant Ability that helps us make sure we never, ever miss any of these codes for these types of procedures. So whether you have insurance or not, the American Dental Association has procedural codes that are used for communication with patients, not necessarily code, but the definition for medical legal purposes. Hey, this is proof of what we did, nothing more, nothing less. And then, of course, for billing. So what we do in cases like this is we can obviously put down the diagnosis. Every case we do, of course, is going to have a comprehensive exam, a CT scan, a digital workup, a treatment presentation done at a different day. Most of these patients are sedated, so there's an IV sedation evaluation. And as we kind of cruise through, sorry, let me get this moving here. So what we want to be able to show is we're doing a fixed, immediate, temporary. We're placing the implant. We're doing a temporary abutment. We're doing a temporary crown with the top cut off, essentially. We're doing IV sedation. Of course, we're going to use more than 2 drugs. We're going to use local anesthetic. We're going to use the Stella Life that we prescribe in the office. We're going to do a surgical extraction. What this software does is it prompts you in your front office to never miss any codes. And so we still accept, I would say, about half of the decent insurances out there. And in doing these types of procedures, never missing a code can substantially increase your honest production in your practice, allow you to slow down and do better work, use better materials. Patients get better results. They're happier. Doctors get better results. They're more fulfilled. It's kind of a win-win. So even if we're in a situation where we need to repair the sinus, which isn't too uncommon, we've got all the procedural codes for that. And ultimately, we keep a running tally of total chair time at the top, what this is costing us overhead-wise, fixed and variable, and then again on profit. And then we can spit out a treatment plan that has all the codes we need for the front office to take care of it. So if you're interested in that, please attend more of our courses. We do have a course on immediate molars coming up August 4th and 5th, just in a few weeks. This is done through the OR Foundation. If you are interested, they do have a 10% discount code, Molar10. If you're interested, we'd love to have you. It's here in Salt Lake, 10 CE credit hours. We go over all this didactic material. Every doctor will drill in models, get the implants placed just right. I'll do a live surgery on Saturday and review complications. So if that doesn't work for you, we also have another one in our office, September 15th and 16th. Feel free to scan the QR code. That'll direct you to the future courses for aesthetic zones, zygomatic implants, full arch, all the fun stuff. So let's move up to the maxilla. This is a little bit different animal, is what I like to tell patients and teach doctors. We all know that the bone is quite a bit softer. We're also dealing with 3 roots rather than 2 on average, sometimes even 4. So it just becomes a little more technique sensitive to treat these immediate molars in the maxilla. So this patient had a root canal done on 15, went to get one done on 14. Endodontist diagnosed it with a vertical root fracture, didn't want to treat it. So now he's in my office to get it out. Just like in the mandible, we want to do a minimally invasive extraction. All that means is we're trying to avoid at all costs making incisions. The only exception to the rule is if there is infection at the apex of those roots. There's nothing wrong with making a vestibular incision, almost as if we're doing a periapical, to remove and ensure that infection's gone for placing that implant. Otherwise, we really want to avoid crustal incisions, sulcular incisions around these teeth. So what's really interesting about the maxilla, if you look down here at the lower left-hand side, typically we'll have 2 buccal roots and then, of course, a palatal root. The palatal root tends to be more commonly displaced to the distal, and that leaves us a purchase point that's slightly more mesial and slightly palatal to create our osteotomy. Now, this is where it gets tricky. You have to anticipate that this septal bone in this trifurcation, radiographically anyway, is going to expand. And where is it going to expand? It's going to expand and enlarge into the path of least resistance, which of course would be the palatal root and the distal buccal root. So one of the keys in starting these is to start with a palatal and also mesial bias, but then look, listen, and feel. The nice thing about these Versa osteodensification drills is you can change the vector as you go, and you can't do that with the traditional twist drills. So here we are with you can see the sinus floor all the way up in that area. This is bone, interseptal bone that we've expanded. And here we are at least 3 millimeters, in this case, 4 millimeters away from the facial plate, as anticipated. We can then use our bone graft of choice. Now, I said putties work great for those gap grafts and fills of those sockets. The neat thing about this Nova bone, however, it's a synthetic bone. It was initially designed for these indirect socket grafts. So this is an indirect sinus graft that we'll be doing in this area. And we use the Versa drills, spinning in reverse, to propel, if you will, that synthetic bone graft material gently up into the sinus, so we can place a nice 7 by 9 millimeter implant in that spot. So here we are, 4 millimeters deep to the free gingival margin, 4 millimeters, at least 3 millimeters away from the facial plate, with a small little sinus bump between that bone. We then want to contain that bone graft and support those tissues with an injectable custom healing abutment. So any of you doctors out there that make temporary crowns, this is an absolute piece of cake. There's no need to, in my opinion, waste money on semi-custom healing abutments from other companies. If you use some 1 to 50,000 epi to get some better vasoconstriction here, you're not dealing with as much heme. You can just throw the temp cylinder on, make sure it's seated passively, inject around it, mark your little reference point, dimple on the side, take it out, polish, and throw it right back in. So here's the example at 4 months of healing. So don't get confused here. This is just a comparison. I put a traditional healing abutment in, which would not contain this bone graft, would not support these tissues. Then we ended up putting in this custom healing cap just 10 minutes later. So this was just there to make sure nothing got down in the implant annulus while we were working on this custom. Patient comes back 4 months later, we remove it. You can see how incredible all this tissue looks. Then we can go ahead and scan that. This is our 25 to 45 degree emergence profile. That's ideal to minimize food impaction and also allow for better flossing cleansability, reducing the proximal caries. Of course, this is a representation of no ceramic glaze below the free gingiva. So if this is screwed in, highly polished zirconia, then tissue will attach to it, and we will see less migration of tissue over time. Then we can place that screw retained crown. I'm a fan of just placing some Teflon tape and conventional composite filling in the screw axis. Literature to support these large diameter implants. Much of it has been done through Southern implants, of course, BioHorizons implants as well. Studies, this is a great study, 51 implants at 23 months, only had 0.15 millimeters of marginal bone loss, and that's with an average or a mean of 116 Newton centimeters. These large diameter implants with significant taper really get a lot of torque, and that torque is totally fine if you're in forgiving bone marrow. It's not okay if you're in avascular or less vascular healed sites. You'll see bone loss in that situation. More studies showing at 67 months. So here we're way past 5.5 years now, less than 0.2 of a millimeter average bone loss. I don't think, let's be honest, I don't know if any of us have really gotten out and measured how many millimeters or 0.1 of a millimeter bone loss there are on any of our implants. But we're grateful for the studies that happen with these jigs and things that allow us to scientifically and objectively study that. If we look at this, you know, a lot of questions I get from doctors and other course attendees is, well, if I torque it more than 35 or 45 Newton centimeters, don't I get some bone loss? And the answer is, again, it depends on the type of bone you're putting it in. Bone marrow is forgiving, it's vascular, it's full of osteoprogenitor cells. Contrast that with healed vascular bone, or I'm sorry, healed cortical bone that is not as vascular, not as forgiving. You'll get more problems. So there is no difference in high versus low marginal bone loss in these cases. In summary on this, 96.6% survival rate of these large diameter implants. And the key take home message is you must have an intact buccal plate and do a gap graft. Ultimately, this procedure will increase patient satisfaction, case acceptance, and of course, profitability for the practice and reduce stress. So whole goal is optimize patient satisfaction and doctor satisfaction. And again, we get these yeah buts. Of course, in the app, I'm just going to fast forward this because we're a little short on time, but we can put all this into the app. The important part here, though, is when we're doing a bone graft like this, we've got a bone graft to fill the sockets. That's a 6104 graft at the time of implant placement. That does not include the bone. The bone is a separate code, the 4265. If we're using osseodensification, technical term is a compaction autograft. That's a bone harvest. If we're doing a sinus augmentation, we've got to differentiate between direct 7951, indirect 7952, and you can very successfully treatment plan these cases, even with insurance rates, and make it a win-win for both the patient and the doctor. As we cruise through these, again, we have a course August 4th and 5th, and then again, September 15th, 16th. Snap a picture of that QR code. If you're interested, we'd love to do that for you and have you at our courses. Again, we bring up the yeah buts again. The whole goal is that we're able to overcome those. I'm going to try and finish early so we can take a whole bunch of questions. These are my cute kids. They remind me every day you have to do scary things or you'll never get better. Right, Dad? They like to say. And as we move forward, keep in mind that this isn't easy. This guy, a lot of you heard of him, Crazy David Goggins, one of the toughest guys in the world, he likes to claim. But this is important, in our line of work. Sometimes we get complacent, don't want to try anything new because it makes us feel uncomfortable. I really appreciate his quote, get comfortable being uncomfortable. If you start doing these immediate molar implants, you will not feel comfortable, and you need to apply the principles, and please consider taking the training. Hands-on is so much better than seeing something online, when you can have an attending or a mentor, if you will, over your shoulder saying, hey, this is what it should feel like. This is what it should look like. This is how to mitigate that and this, and get good results. So get comfortable feeling uncomfortable, do the work, and remember, never be so sure of yourself that you won't do something better. Excellence matters. So we have course again, August 4th and 5th. If you're interested in that, here in Salt Lake City, small little QR code down there. Sorry, a bigger one. This is through the OR Foundation. We only have a couple spots left. If you're interested in that, that's just in a few days. Then we have another one again in mid-September. If that works better for you, snap a QR of that one. If you're interested, we'd love to have you. Again, we go over all these techniques. We do them on models. We put the bone grafts in, all that fun stuff, make the temporary custom healing abutments, and then do a live surgery the following day that everybody can see. We also help people make sure they don't miss any of these important procedural codes for patient communication, medical liability, and of course, to submit for billing. The whole goal is that we could turn these yeah buts into let's do this. I appreciate your attendance, and I'll be looking forward. We got a whole bunch of chats and Q&As that we're going to be going over now. So I'll just go ahead and read those. But please, 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 if you're interested in doing these, there's really no substitute for taking a course. If it's not mine, that's fine. Make sure you take a course on these immediate molars because they can be very technique sensitive. Do I use I use a lab called Epic in American Fork, another one called Diamond Head here in Utah. Any lab that takes the time these days to slow down and communicate with you. It's super important that the lab's willing to be on a text thread. I think that works better than even emails sometimes, where you can instantly take those pictures, send them to the lab, not only shade match but emergence profiles, and explain what it is that you're trying to accomplish. Sometimes we'll expand the emergence profile, sometimes we won't. It just depends on the tissue position, thickness, and what we're trying to accomplish. So my advice is any good lab that's willing to communicate with you and follow your prescription. I say that all the time too. You're writing a prescription, not a suggestion. And a lot of labs these days just fill these prescriptions however they see fit. But the idea is to fill it as if it were a medication, exactly as written. If we go to more, let's say, here's the first question. Another good question is, how do you place membranes when you do immediate implant with bone graft and temporary crowns? That's a loaded question. When we do membranes and temporary crowns, that's typically going to be in the aesthetic zone. We do have an aesthetic zone course online and hands-on, but you have a myriad of options. It depends on how much facial plate you have left. That's been well documented in the literature. If you have less than 50% of the facial plate left, I highly discourage you from attempting that. It is possible in a super healthy patient with thick tissue, excellent compliance, and a hell of a lot of luck. You might get away with that, but otherwise, I would limit that to having 50% or more of the facial plate. But you have a few different options. Sometimes it's a combination of Dennis Tarnow's ice cream cone technique, where you can sneak that little membrane up underneath. You can place bone in that site and then screw down your membrane. Dr. Barry Levin out on the East Coast teaches a dermal apron technique, which is basically you make your temporary crown that's out of occlusion with proper emergence profiles, and you take a small piece of dermis and you place a hole. Think of it like a biopsy punch, drape that over the temporary from basically the intaglio down, screw that in, and then you can tunnel up and tuck it underneath. Lots of different ways to do that. I'd recommend you consider taking the advanced course if you're interested in that. Got another good question. So sub-G, highly polished zirconia, but no glaze. That is correct. And that's well documented in the literature. It doesn't even need to be. Think of all of the crowns that we see that have recession around them. Most of them are old PFMs, and that's proof, or even the zirconia crowns, that's proof that tissue does not attach to that surface. Where we do know that titanium and also the zirconia will attach to tissue, because as you remove those components, they might rip a little bit, they might bleed a little bit, and that shows that attachment is there. So let's see. Can you send info on implant and bone graft codes? Yes, if you get on implantability.com, it'll show you all of those things and all of those codes, no problem. And then, of course, we go over those on all the courses. So do you place a membrane under your, let's see, provisional, I'm assuming, crowns? The answer is no. So the membrane, think of a collagen membrane is there it's technically called a barrier to cell infiltration, right? So it's a cell occlusive barrier. You don't want the tissue to grow into your bone graft before the bone graft gets a chance to heal. When you have an intact facial plate, which is a prerequisite for these immediate molars, the facial plate essentially acts as a membrane to discourage tissue migration and epithelial migration into that spot. The custom healing abutment, as long as it's highly polished, obstructs that bone graft, supports the tissues. Yes, that's going to epithelialize underneath, but typically the body will always form that biologic width of 3 to 4 millimeters of tissue immediately under that custom healing abutment. Hopefully that makes sense.